Welcome to The Explainer. Today, we're diving deep into secondary peritonitis. Now, this isn't just any infection. It's an acute, full-blown crisis in the abdomen that often follows a perforation. This is a situation where swift, precise clinical action is everything. It's what stands between the patient, sepsis, and a potentially fatal outcome. So, let's get right into it. All right, here's how we're going to tackle this. We'll start by defining the threat and what causes it. Then we'll get into the detective work, finding the microbial culprits. After that, we'll move on to our therapeutic strategies, talk prevention, and finally, face the serious complications that can arise if we don't get this right. So let's start at the beginning. What exactly is secondary peritonitis, and where does it come from? At its heart, secondary peritonitis is the peritoneum, the lining of your abdominal cavity, on fire, basically. It's an intense inflammatory response. And that word secondary is absolutely key. It means this isn't random, it's the direct result of a breach somewhere else in the abdomen, usually a perforation that lets the gut's own microbiome spill out into the normally sterile peritoneal space. And the list of potential causes is, well, it's long. GI perforations are the classic culprit, of course, but you also have to think about things like necrotizing pancreatitis, where digestive enzymes basically start digesting the body from the inside out. And we can't ignore iatrogenic events, things that happen after surgery or an endoscopy. It's a stark reminder of just how complex the abdomen really is. Okay, so once we suspect peritonitis, the race is on to identify the microbial invaders. Getting this right is the absolute cornerstone of good therapy. It's what lets us move from a shotgun approach to a sniper rifle attack. And that starts with meticulous collection. You have to inoculate those culture bottles, both aerobic and anaerobic, right there at the bedside. Why? Because those fussy anaerobes will die off in transit if you don't. That separate sample for a gram stain, that's our first, fast clue about what we're up against. And if the cultures keep coming back negative after a few days, that's when you have to start thinking outside the box and hunt for more unusual pathogens. So what does the usual rogues gallery look like? It's almost always a polymicrobial party, a direct reflection of whatever part of the gut just ruptured. As you can see, gram-negatives like E. coli tend to dominate, but you absolutely cannot ignore the anaerobes and enterococcus. They're a huge part of the problem. This polymicrobial reality is exactly why we have to start with broad-spectrum antibiotics. And we can't forget the fungi. Candida species are a huge problem, especially in patients who are post-op or immunocompromised. They're masters at forming biofilms on things like peritoneal catheters, which makes them incredibly tough to kill. Which, brings me to a little microbiology humor. Why did the bacterial colony break up with the biofilm? Because they felt too attached. Okay, let's put this to the test. You have a 62-year-old male, known diverticulitis, now has peritonitis from a perforation. Look at this list. Which one of these pathogens is the least likely culprit? Is it A. E. coli, B. Bacteroides fragilis, C. Staphylococcus epidermidis, or D. Enterococcus faecalis? The answer is C. Staph epidermidis. Think about it. Staph epi lives on the skin. It's a major player in catheter-related infections, for sure. But for a colonic perforation, you're expecting gut bacteria, E. coli, bacteroides, enterococcus, and that leads us perfectly into treatment. This is really where the art of infectious disease management comes into play, moving from that initial broad coverage to a highly specific targeted attack. When you're staring down the barrel of sepsis, you don't wait, you act. We hit them hard and fast with a powerful empirical regimen like this one. You've got cefuroxime for broad coverage, gentamicin to hammer the gram-negatives, and metronidazole specifically for those critical anaerobes. This is the holding action, the critical bridge that buys us time until we get those culture results back. And once those results are in, we pivot. This is the principle of de-escalation. If the lab calls and says it's candida, you start an antifungal like fluconazole. If it's MRSA, you switch to vancomycin. And in both cases, you have to think about source control. That infected catheter, it almost always has to come out. It's a fortress for the microbes. Now, treating kids is a whole different ballgame. Dosing is everything, and it must be meticulously calculated based on weight using a pediatric formulary. That's non-negotiable. It's also interesting that with intra-abdominal abscesses in children, we can often be more conservative, with antibiotics alone doing the trick. And if we do need to drain, the go-to is now a minimally invasive, image-guided approach. Let's try another case. A patient's culture comes back positive for Candida albicans. What do? A. Keep going with the antibacterial drugs. B. Stop everything. C. Start fluconazole and think about pulling the catheter. Or D. Switch to flucloxacillin. The answer is C, and it's not even close. You have a fungal pathogen, you must use an antifungal drug. Just continuing antibiotics would be a massive error, as fungal peritonitis carries an incredibly high mortality rate if you don't treat it directly. One last one, this time in pediatrics. A kid gets an abscess after an appendectomy. If you have to drain it, what's the preferred method? A. Open surgery only. B. Never drain, just use antibiotics. Or C. Percutaneous drainage with imaging guidance. The clear winner is C. The modern standard of care is this minimally invasive, image-guided technique. It's just as effective and has way lower morbidity than cutting the child open again. Okay, let's switch gears to prevention. Because honestly, the best treatment for peritonitis is for it to never happen in the first place. Mitigating that risk is just as important as anything else we've discussed. Now, this number might seem small, but for a patient on peritoneal dialysis, it is hugely significant. We want to keep their serum potassium above 4.0. Why? It's simple, really. Hypokalemia, low potassium, screws up gut motility. A sluggish gut means a weaker barrier, making it much easier for gut bacteria to cause trouble. And that's just one piece of a much larger puzzle. Prevention is all about building layers of defense. We're talking prophylactic antibiotics before high-risk procedures, relentless training on aseptic technique for dialysis patients, and active surveillance for resistant bugs. Each one is another brick in the wall protecting the patient. And finally, we have to talk about what happens when our defenses fail, when the infection isn't controlled. The stakes here are as high as they get. For someone on peritoneal dialysis, getting peritonitis can be a life-changing disaster. It is a leading cause of what we call technique failure, forcing them to switch permanently to hemodialysis. And if it's fungal peritonitis, that's an absolute nightmare scenario with high rates of recurrence, hospitalization, and frankly, a distressingly high mortality rate. And the damage often spreads far beyond the abdomen. The specific pathogen can cause its own brand of systemic devastation. C. diff can lead to a perforated bowel. Gonococcus can spread, causing septic arthritis or endocarditis. And even something like group A strep can trigger post-infectious syndromes like rheumatic heart disease, years after the initial infection is gone. A failure of source control can have lifelong consequences. So this brings us to a final and frankly pretty sobering question for all of us. We have these therapeutic playbooks that we rely on, but the enemy is constantly changing. As multi-drug resistance continues to explode, are the tools we have today going to be enough for the superbugs of tomorrow? It's a question that highlights just how vital antimicrobial stewardship and continued innovation really are. Thank you for joining this explainer.